Hi class, welcome to today's today's flip class. So for today's flip class, we're going to talk about disorders of bone and mineral metabolism. So this lecture will be divided into two parts. So this video covers part 1. So here is the outline of our lecture. We're going to talk about bone and mineral metabolism. So particularly we'll focus on calcium and phosphorus and the different hormones that control your mineral metabolism, particularly your PTH, and in pathologic states, your PTH related peptide, and then your vitamin D and also your FGF23. And then we're going to discuss the different disorders of the parathyroid gland and how they affect calcium homeostasis. No? So we're going to talk about disorders causing hypercalcemia and disorders causing hypocalcemia. And lastly, we're going to talk about bone metabolism, and osteoporosis. So about 99% of the 1 to 2 kilograms of calcium is normally present in our skeleton. And your skeleton not only provides mechanical stability or framework for our body, but also serves as a reservoir, no? And in order to be able to store calcium, and so anytime our body needs calcium in the extracellular fluid compartment, it can get calcium from our bones. So your calcium majority will be in your bones and in your teeth. A small amount will be intracellular, about 1%, and a very, very small amount will be in your extracellular fluid in your plasma. No? And the biologically active form of your calcium is your ionized calcium in the ECF. And this one is the one that controls our body processes. No? So your phosphate, on the other hand, will be also majority will be in the bones, and a small portion will also be about less than 1% will also be in the ECF. But unlike your calcium, a lot of your phosphate will also be located intracellularly, about 14 to 15%. So in the plasma, no, your calcium will either be bound to albumin or ionized. So 50% of calcium in the plasma will be bound to your albumin, and this is the inactive form. 50% of your calcium in the plasma will be ionized, and this one is your active form of calcium, and this one is very tightly controlled. So the level of calcium, your ionized calcium in the blood, can be affected by your blood pH, because your blood pH affects calcium albumin binding. So in disease states that cause your blood pH to be acidotic, let's say you have diabetic ketoacidosis or you have septic shock, your calcium becomes less tightly bound to albumin, therefore you will have high ionized calcium. In disease states where you have alkalosis, let's say you're hyperventilating causing respiratory alkalosis, your calcium becomes more tightly bound to your albumin. So you will have low ionized calcium. So your calcium homeostasis is an interplay of calcium intestinal absorption, calcium renal excretion, as well as calcium deposition and calcium resorption from your bone through bone remodeling. So your calcium balance will be determined by net intestinal absorption that should be balanced by urinary excretion. No? So the recommended daily allowance for calcium will be about 1,000 to 1,200 milligrams for most adults. So a tablet of caltrate will contain about 600 milligrams of calcium, and a glass of milk will contain about 300 milligrams of calcium. But of course, we get calcium from other sources as well, such as dairy, fish, and other vegetables as well. So let's say you take about 1,000 milligrams of calcium in a day. No? About 350 milligrams of that will be absorbed in your intestines through your vitamin D. But about 250 milligrams of that will be secreted in your intestines. So about 900 milligrams of calcium will be excreted in the feces out of the 1,000 milligrams. No? majority of the calcium that is filtered in the kidney will also be reabsorbed, and this calcium reabsorption in the kidney is facilitated or regulated by your parathyroid hormone, and about 1000 milligrams of calcium is excreted in the urine per day. So if you have a normal calcium balance, the amount of calcium that is deposited in your bones will also be the same amount that will be resorbed in the bone. So in disease states where you, in states where you have, let's say, a negative calcium balance, no, in negative calcium balance, calcium calcium deposition, there is more calcium that is resorbed than is deposited. So states like pregnancy and lactation will be states of negative calcium balance. No? In positive calcium balance, more calcium is deposited into the bone that is resorbed. So an example of a positive calcium balance will be growing children. So calcium is we mentioned earlier that calcium is reabsorbed in your kidneys. So majority of the filtered calcium in the urine will be um, reabsorbed in the proximal convoluted tubule, about 65 to 70% through a paracellular mechanism. And this is affected by the amount of sodium um, in your tubules. No? In the cortical thick ascending loop, it's also about 20% of the filtered calcium is also reabsorbed. No? And this is also reabsorbed through paracellular mechanisms. In the distal convoluted tubule, you have active transcellular reabsorption. This is where fine regulation of calcium reabsorption takes place, and this is tightly controlled by your parathyroid hormone. So, the filtered calcium that reaches your distal convoluted tubule will be reabsorbed by your TRPV5 transporter, and once inside, it binds to your calbindin B28K, and which facilitates the exclusion of your calcium into the basolateral side of your tubules through your sodium calcium exchanger. And your sodium calcium exchanger is powered by your sodium ATPase pump. So as you can see, this is similar also in your collecting duct. So as you can see, the reabsorption of calcium is affected by the amount of sodium in your tubule. So therefore, let's say in the proximal convoluted tubule, if you have a high sodium load, no, this inhibits calcium reabsorption. And likewise, no, your diuretic, your furosemide, also increases sodium in your tubules, causing limiting the amount of calcium that is reabsorbed, causing calciuresis. So your saline infusion and your loop diuretics can cause hypocalcemia. And this is important in patients with hypercalcemia, because in hypercalcemia, um, your we can give patients with IV saline infusion to hasten the excretion of your calcium. And also, furosemide is also one of the treatment regimens that we give in patients with hypercalcemia, because they help excrete, no, your calcium in the kidneys. On the other hand, your thiazide diuretics depletes sodium in your distal convoluted tubules, and by depleting sodium in the distal convoluted tubules, it actually hastens the reabsorption of, or augments calcium reabsorption, causing hypercalcemia. Next, we discuss phosphorus. No, so your phosphorus also exists in three forms. No, um, in the bones as complex to calcium in the form of calcium hydroxyapatite, and intracellular in your nucleotides and in your ATP, ADP. So in the plasma, no, majority will be in the ionized form or your active form. About 12% will be bound to protein, and less than 3% will be bound to cations in the form of your calcium phosphate, your magnesium phosphate, or your sodium phosphate. So your kidneys is also central in phosphate reabsorption, no? And just like your calcium, majority or about 80% of your filtered phosphate is reabsorbed also in the proximal tubule. And a lesser degree, no, about 8 to 10% will be filtered in the phosphate, and the rest are excreted in the urine, no? So your PTH and your FGF23, your phosphaturic hormones, inhibits phosphate reabsorption, while your vitamin D, which we will discuss later, will facilitate phosphate reabsorption. So how does PTH inhibit renal phosphate reabsorption? So when your PTH receptor, when your PTH binds to your PTH receptor in your kidney, it sends a signal through your G protein, and you're activating your adenylate cyclase, causing activation of ATP to your cyclic AMP, causing phosphorylation of several enzymes. And this eventually leads to the inactivation of your sodium phosphate cotransporter. So if you inactivate this, your phosphate will not be reabsorbed. So next we have your FGF23. So this hormone inhibits the sodium-dependent phosphate transport in both your intestinal and renal epithelia. No? So by inhibiting phosphate reabsorption, no, it lowers down your phosphate in the blood. Your FGF23 also suppresses your vitamin D. Remember, your vitamin D facilitates phosphate reabsorption in the kidneys and in the intestines. And by blocking this action of vitamin D, your FGF24 also blocks the reabsorption of your intestinal and renal phosphate reabsorption. Your FGF23 also facilitates phosphate excretion by activating your FGF receptor, and when your FGF receptor is activated, it releases the sodium phosphate cotransporter in the plasma membrane. So therefore, your phosphate cannot be reabsorbed in your tubules. Your FGF23 is regulated by the amount of the phosphate you take in the kidneys, as well as the amount of phosphorus in your blood, as well as the levels of vitamin D. So there is a disease entity called autosomal dominant hypophosphatemic rickets. So this is how, in these patients, this is how they discovered the existence of your FGF23 causing phosphate metabolism. So in these patients, they have very, very, very low phosphate levels in the blood, and they discovered that in these patients there is a mutation of the gene encoding FGF23, and this is how they discovered how FGF23 controls phosphate metabolism. Next, we're going to discuss vitamin D. So vitamin D is very important in mineral metabolism. So normally we get vitamin D by sunlight exposure, but we can also get vitamin D from food sources such as your dairy, your fish, your healthy cereals, and the recommended daily intake of vitamin D is about 600 IU, and it could be higher in elderly individuals more than 70 years old. So your calcium, your caltrate tablet contains about 200 to 400 IU of vitamin D. So your activated vitamin D, your 125 dihydroxy vitamin D or your 125 dihydroxycholecalciferol is a major steroid hormone involved in mineral ion homeostasis, and it provides both calcium and phosphate to the extracellular fluid for bone mineralization. No? So it's a hormone, more of a hormone than a vitamin. Your 25 hydroxy vitamin D or your calcidiol. This one is calcitriol and this is your calcidiol. This is the major circulating and storage form of vitamin D. So once your 7-dihydrocholecalciferol is hydroxylated in the liver, it becomes 25 hydroxy vitamin D. No? And it's bound to your vitamin D protein. So it's the best index of vitamin D sufficiency. So when you test patients for vitamin D, this is actually what we measure, not your 125 dihydroxy vitamin D. Now your 25 hydroxy vitamin D, let's see if I have a slide for that. So let's say your 7 dihydrocholesterol is activated by sunlight, it becomes cholecalciferol, or if you take it from food, it becomes your ergocalciferol. It's hydroxylated in the kidneys, in the liver by your 25 hydroxylase enzyme, and to become your 25 hydroxy vitamin D or 25 hydroxycholecalciferol. And then in the kidneys, it's acted upon by your 1-alpha hydroxylase to become your activated vitamin D, your 125 dihydroxycholecalciferol. Now, your 1-alpha hydroxylase activity is increased by the following factors. So, if you have a low serum calcium, your 1-alpha hydroxylase activity is activated in order to facilitate calcium reabsorption. Your PTH levels also activates your 1-alpha hydroxylase activity as well as low serum phosphate in order to be able to reabsorb phosphate. No? So your activated vitamin D is metabolized by your 25 hydroxylase to become your inactive vitamin D or your 24-25 dihydroxycholecalciferol. So your activated vitamin D facilitates both intestinal calcium and phosphate reabsorption, and this action is similar also in your kidney. So your vitamin D also facilitates both calcium and phosphate reabsorption in the kidney. So essentially, no, your vitamin D facilitates calcium and phosphate reabsorption both in the intestine and in the kidney. At the same time, your vitamin D also increases bone resorption in order to provide more calcium and phosphate from old bone to mineralize new bone. And your activated vitamin D strongly suppresses your PTH. So if we tie them up together, your actions of your PTH and your vitamin D, let's say you have low calcium levels, it's sensed by your calcium sensing receptor in your parathyroid gland cells secreting your PTH. No? Your PTH, the low calcium, causes the release of your PTH from your parathyroid gland, causing calcium and phosphate resorption from the bone, and your PTH also activates your 1-alpha hydroxylase in the kidney, activating your vitamin D, and your PTH also increases calcium reabsorption and phosphate excretion. So the end result of your PTH will be an increase in calcium and a decrease in phosphate. Your vitamin D, on the other hand, no, once your stored vitamin D is activated when your 1-alpha hydroxylase, your activated vitamin D facilitates calcium and phosphate absorption both in your intestine and in your kidneys, and also facilitates calcium and phosphate resorption. So the end result of your vitamin D would be both an increase in calcium and phosphate levels in the blood. So you see the contrast between your PTH and your vitamin D. So we talked briefly about PTH in the earlier side. So your just to reiterate, no, your PTH, no, coordinates the increase in serum calcium in the plasma and a decrease in the serum um, phosphate. So it does this by increasing bone resorption and inhibiting renal phosphate reabsorption in the proximal tubule, hence its phosphatory effect. And in the calcium, it increases renal calcium reabsorption in the distal tubule, and it increases intestinal calcium absorption by activating your 1-alpha hydroxylase, therefore activating your vitamin D. No? So the end result of your PTH is to preserve calcium in the blood at the cost of bone mineralization. So your PTH receptor is found both in your osteoblast in the bone and in the distal tubules in the kidney. So how does PTH act on the bone? So your PTH activates bone resorption by binding to your osteoblast. When your PTH binds to your osteoblast, it facilitates the formation of your rank. And your rank is now able to rank ligand, and your rank ligand will now be able to bind to your rank ligand in rank receptor in your pre-osteoclast. And once your rank ligand binds to your rank to your pre-osteoclast, it activates your pre-osteoclast to become your activated osteoclast. No? At the same time, your PTH also inhibits your osteoprotegerine. So your osteoprotegerine is the substance that blocks the activation of your pre-osteoclast to your osteoclast. So essentially, the end result will be the activation of your osteoclast, both by activating rankel and inhibiting osteoprotegerine. So your activated or your mature osteoclast secretes acids, no, from your lysosomes in order to resorb your bone and release your um, calcium from your bone. So if you have a high calcium levels in the extracellular fluid, this binds to your calcium sensing receptor, and the activation of your calcium sensing receptor leads to inhibition of your PTH secretion. So therefore, if you have high calcium levels, your PTH levels will be low. Now, if you have low calcium levels, so the calcium sensing receptor will not be activated, and this leads to continuous PTH secretion. So it's not inhibited. So therefore, your PTH is released into your body. So therefore, if you have low calcium, there is a increase in PTH. So if you have low calcium, there's an increased PTH, and your PTH now activates all the mechanism in order to bring back your calcium back to normal levels. So there's also a hormone called the parathyroid hormone related protein that normally in normal individuals don't have any effect in calcium metabolism. However, in disease states such as in um, malignancies, let's say your breast cancer or your colon cancer, no, these tumors can secrete a lot of parathyroid hormone related protein or your PTHrP. And in disease states, no, your PTHrP mimics your parathyroid hormone and acts on the PTH receptors in your bones and in your kidneys. So this is and if you have an excess in your PTHrP, you will have humoral hypercalcemia of malignancy. So this is a syndrome that resembles primary hyperparathyroidism but without elevated PTH levels, no? So in this disease, no, your PTHrP is secreted from the tumor and acts on the receptors of your PTH in the bone and kidney to raise your calcium levels, no? So developing hypercalcemia. So we go to hypercalcemia. So what are the different manifestations of hypercalcemia? So traditionally, no, hypercalcemia manifests as stones, bones, groans, and abdominal moans. So usually that's the mnemonic that is taught to medical students, no? But when we say stones, or we mean renal stones, no, usually in the form of nephrolithiasis, nephrocalcinosis, no, dehydration, even nephrogenic DI. In bones, you will have bone pains, arthritis, osteoporosis, and even osteitis fibrosis cystica in hyperparathyroidism. For gastrointestinal moans, you can have nausea, vomiting, constipation, abdominal pain, and in cyclic groans, you can have mental status changes, confusion, even coma, and um, even seizures. No? And in cardiovascular, you can have hypertension, cardiac arrhythmias, vascular calcification. In the skin, you can have itching. In the eyes, you can have keratitis, conjunctivitis. But presently, these symptoms of hypercalcemia is now not as common as it was before because now we have calcium has been included in some, blood chemistry panels. So sometimes we catch hypercalcemia even if the patients are still asymptomatic. So usually we see this only in um, more profound hypercalcemia cases. What are the different causes of hypercalcemia? So we can divide this into parathyroid-dependent hypercalcemia and parathyroid-independent hypercalcemia. So in parathyroid-dependent hypercalcemia, you can have primary, tertiary hyperparathyroidism. You can also have familial hypocalciuric hypercalcemia, which we will discuss later, and as well as lithium-associated hypercalcemia. But for your purposes, just focus on hyperparathyroidism. No? In parathyroid-independent hypercalcemia, these are the ones that are caused by your cancer, excess vitamin D, other endocrinopathies, even drugs. No? Another way of putting this is from your Harrison. You can classify causes of hypercalcemia with parathyroid-related, no? As I mentioned earlier, hyperparathyroidism, and lithium, and your FHH or your familial hypocalciuric hypercalcemia. And then you can have malignancy related, vitamin D related, associated with high bone turnover, that's your hyperthyroidism, immobilization, vitamin A, etc. And those associated with renal failure, that's your secondary hyperparathyroidism, milk alkali syndrome, etc. So if you have a patient with hypercalcemia, usually we confirm it with another blood calcium levels, either total calcium with an albumin level or your ionized calcium. If it's really persistently elevated, then you look at the clinical picture of the patient. By history, physical exam, does the patient have excess ingestion of vitamin D? Does the patient have cancer, etc.? No? And then we measure the different other electrolytes as well as your BUN, creatinine, phosphate, and alkaline phosphatase. And then, in order to determine whether this is a PTH dependent or PTH independent, we measure serum PTH. No? If the serum PTH is low, in the light of hypercalcemia, then we say it's appropriately low. The hypercalcemia is suppressing PTH, and this is what we call PTH independent hypercalcemia. No? Usually, this is caused by a malignancy. So, if there's no known malignancy, you can look for an occult malignancy. If there's none, then you evaluate for other PTH independent causes of hypercalcemia, like what we said earlier, immobilization, vitamin D, hyperthyroidism or thyrotoxicosis, etc. Kidney, if there's malignancy associated hypercalcemia, then we treat the malignancy and consider giving medications to treat the hypercalcemia. In PTH independent hypercalcemia, you have a high PTH causing the hypercalcemia, or you have an inappropriately normal PTH in the light of hypercalcemia. So that's what you call PTH dependent hypercalcemia. Okay? Usually, either primary hyperpara, tertiary hyperpara, FHH, and your lithium. So if you don't have any lithium, you can easily exclude that. No? In patients with hyperparathyroidism, we have primary, secondary, tertiary. In primary, the problem is in your parathyroid gland. You have usually parathyroid adenoma from your parathyroid gland causing excess secretion of your PTH, causing high calcium levels, no? Or hypercalcemia. In secondary hypercalcemia, you have disease condition causing low calcium. So what are those disease conditions? Usually, chronic kidney disease. No? Chronic kidney disease, you have low calcium stimulating your parathyroid gland to secrete more PTH. No? This is a compensatory mechanism for hypercalcemia. Now, in long-standing cases of that low calcium, no? Let's say in chronic kidney disease, you have initially low calcium causing elevated PTH. If this is prolonged enough, your parathyroid glands develop an autonomous PTH adenoma because of overstimulation causing hyperplasia. No? And the development of this autonomous PTH adenoma causes excessive PTH secretion. This is what we call tertiary hyperparathyroidism. No? So in primary hyperparathyroidism, usually you have a high calcium or with an inappropriately normal PTH or an elevated PTH, no? There's also such a thing as a normocalcemic hyperparathyroidism, but those are not very common. Sometimes there's a concomitant vitamin D deficiency or lithium, no? So the presentation, again, moans, bones, stones, groans, and others, no? But now majority of the patients are asymptomatic because we catch them early by routine serum chemistry. So usually part of the serum chemistry, you will have calcium, and then you see that the calcium is high, and then we investigate it, we find that patient has PTH dependent hypercalcemia even without the patient having any symptoms. So that's your asymptomatic primary hyperparathyroidism. But that's majority are asymptomatic. So primary hyperparathyroidism majority is still caused by a parathyroid adenoma. To a lesser degree, your parathyroid hyperplasia, and lastly, you have the very rare parathyroid carcinoma. These are patients who have very, very high calcium levels, no? Very difficult to treat. No? I've seen one case of parathyroid carcinoma from my colleague, and this patient actually had bone tumors from the hyperparathyroidism. No? Usually, we're able to diagnose parathyroid carcinoma if there is characteristic histopathologic changes, plus there has to be or there's local invasion even without the histopathologic changes, or there's a lymph node or distant metastasis. So in patients with PTH dependent hypercalcemia that you suspect to have um, primary hyperparathyroidism, it's very important to differentiate between primary hyperparathyroidism and familial hypercalciuric hypercalcemia. They present both with high calcium, high PTH or normal PTH, but the treatment is markedly different. No? So in primary hyperparathyroidism, usually it's surgical. In FHH is usually medical. So first step is to determine the 24-hour urine calcium and creatinine. If the urine calcium is less than 100 milligrams per day, meaning you have hypocalciuria, no? Yes, and then the PTH is normal, no? The patient is relatively young, age less than 40, or have a family history um, of hypercalcemia, then you can say the patient has FHH. And usually FHH is managed um, medically. No? If you have an elevated urine, if you have urine calcium more than 100 milligrams per day, no? Or the PTH is markedly high, then you investigate for primary hyperparathyroidism or lithium therapy. Of course, in lithium therapy, you ask the patient, or the patient has a bipolar disorder, or you look for evidence in the house, no? So you just consider stopping lithium therapy. But if you suspect more of primary hyperparathyroidism, we perform bone densitometry. Usually, bone densitometry will include the wrist. The wrist. Traditionally, a routine bone densitometry would only include your hip, femur, and total. But if you're suspecting primary hyperpara, you have to specify to include the wrist, no? To look for cortical osteoporosis, no? If the patient is confirmed to have primary hyperparathyroidism, you look for the parathyroid gland, and you recommend to remove the parathyroid adenoma through a parathyroidectomy. No, if the patient is not a candidate for surgery, then you just do medical management. So how to look for the parathyroid adenoma? Usually we do a Sestamibi scan. It's a nuclear medicine procedure where you can actually you give the patient Sestamibi isotopes, and you scan them, and you look for where the Sestamibi goes, and usually that's where your parathyroid adenoma is. No? It's more sensitive and specific compared to your routine ultrasound. No? So I mentioned earlier about patients who have asymptomatic primary hyperparathyroidism. So if they don't meet the indication for surgery for primary hyperparathyroidism, usually we just monitor them. No? So every year we do serum calcium, creatinine, and bone mineral densitometry. No? And occasionally you can request for 24-hour urinary calcium. So when to refer patients for surgery? No? So these are the different indications. So if you have overt clinical manifestations of disease, no? Let's say kidney stones, CKD, neuromuscular disease, life-threatening hypercalcemia. If you have a serum calcium more than 1 milligram per deciliter, the upper limit of normal. If you have a creatinine clearance of less than 60, presence of stone, either by CT, ultrasound, or X-ray. If you have a excessive urinary calcium excretion at more than 400 milligrams per day, increasing the risk for stone formation. If you have osteoporosis or a BMD less than 2, P-score less than negative 2.5, or if you have any vertebral fracture by radiograph or by VFA in your DEXA, if you have a history of fragility fracture, if you are young, no, because if you are young, you're still able to develop all the complications of primary hyperparathyroidism if you have uncertain prospect for adequate medical monitoring. So guys, to help you remember the indications for surgery in primary hyperparathyroidism, you just remember this, no? 1, 2, 3, 4, 5, 6. 1, if your serum calcium is more than 1 milligram per deciliter, the upper limit of normal. 2 to 3, if your T-score in your bone mineral densitometry is less than 2.5, no? And then 4, if your urinary calcium is more than 400 milligrams per day. 5, if your age is less than 50. 6, if your creatinine clearance is less than 60 ml per minute. No? So if you're opt not to proceed with surgery, if you opt for non-operative medical management, which are the things that you will advise to your patient? So true or false, will you recommend maintain adequate hydration? Will you recommend avoiding diuretics? Will you recommend avoiding prolonged immobilization? So the answer for the first 3 is true. No, you always have to advise your patients to hydrate themselves, avoid um, diuretics, and avoid prolonged immobilization. Do you need to restrict dietary calcium? The answer is false. No? Whether the pharmacologic approach to primary hyperparathyroidism, if you opt for non-operative management, no, in patients who have low BMD, you can give oral bisphosphonate in order to increase bone mineral densitometry, but it won't have any effect on your calcium or your PTH. In patients who have very high calcium, you can give Cinacalcet to lower down your calcium levels, but it won't have any effect on your BMD. But it also lowers your PTH, no? So you can actually combine Cinacalcet and alendronate if in order to lower down your calcium and also increase your bone mineral densitometry and lower your PTH levels. So how about patients with severe hypercalcemia? Patients with severe hypercalcemia, usually in the clinics we see them more in cancer patients, humoral hypercalcemia of malignancy. So how do we treat? First line will still be rehydration. Usually we give 2 to 4 liters per day of saline infusion. If it doesn't work, we can give furosemide, or if the levels are very high, we can combine both. If it's still not working, the calcium level is still very, very, very high, we can give permidronate, zoledronic acid, or even denosumab. Of course, the doses for your anti-resorptive drugs will be much higher compared to the doses that we usually give for your osteoporosis. No? Calcitonin in the form of spray can also be given, no, as an adjunct in patients with severe hypercalcemia. So I mentioned earlier about FHH, or your benign hypercalcemia. No? Your FHH, your familial hypocalciuric hypercalcemia. In these patients, the calcium sensing receptor is inactivated. No, one copy of the calcium sensing receptor gene is inactivated. So in essence, no, your 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 calcium is reabsorbed all the time, most of the time, no? So you have very low calcium in the urine. So the daily calcium excretion is less than 100 milligrams per day, no? If the calcium creatinine clearance ratio is less than 0.01, then you can also consider that as FHH. Okay, and this is managed, no, medically. No, there's no parathyroid adenoma that we can remove in FHH. So this is the end of your part 1. So I'll upload the video, the part 2, in the next video. Okay? Just comment in the just put your questions in the comment section down below.